All right, let's go ahead and get started. Good evening, and thank you everyone for joining us on this virtual community lecture focused on treating and surviving stroke. I'm Treasurer, Manager of the Neuroscience and Stroke Program here at Providence Little Company of Mary Medical Center, Torrance. And we are joined by our stroke experts, Dr. Allison Arch and Dr. Jason Tarpley, along with our acute rehab liaison, Julie Wong. Before we get started, I want to let everyone know this is a 90-minute event, and we will have plenty of time at the end of the presentations for any questions. So please type any questions you have throughout the event in the Q&A box that's located at the bottom of your screen. Now, before I introduce our first speaker, I want to take a moment to share a little bit about our comprehensive stroke services at Providence Little Company of Mary, Torrance, and San Pedro. Combined, both hospitals are considered part of a robust stroke systems of care. What that means is that the South Bay residents no longer need to leave the community to receive cutting-edge treatment for stroke. As the first designated comprehensive stroke center in LA County, Providence Little Company of Mary Medical Center is certified to receive complex stroke patients not only from EMS, but from other hospitals nearby. However, caring for our stroke does not stop at just the hospitalization. Providence Little Company of Mary Medical Center San Pedro's CARF-accredited stroke specialty acute rehab program allows stroke survivors access to the advanced therapies and technologies which ease their way to a smooth recovery. Lastly, I want our attendees to know that the information provided for educational purposes is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. Now, it's my pleasure to introduce Dr. Allison Arch. Dr. Allison Arch is a board-certified neurologist with fellowship in vascular neurology. She has been at Providence Little Company of Mary Torrance for the past 6 years, where she serves as the medical director and treats hundreds of stroke patients per year. Dr. Arch also sees general neurology patients in clinic who have a wide range of disorders ranging from chronic migraine to dementia to multiple sclerosis. Her favorite part of neurology is working on a multidisciplinary team to manage her patients. She also enjoys getting to know her patients and their families and helping them through their most vulnerable times. In her free time, you can find Dr. Arch spending time outdoors with her husband and her 2 young children. Now off to you, Dr. Arch.
Great, thank you so much, Treasure, and welcome everyone. We're here to talk a little bit about stroke. I'm going to start the talk here talking about just a patient. This is sort of a generic patient or a patient that we see on a daily basis. This is typical of the stroke patients that we see. So this is Fred. Fred is an active 79-year-old man, and he went to play tennis one day. When he walked into the tennis court, his tennis partner noticed that he suddenly dropped his racket and couldn't speak. So what was going on here? Could Fred be having a stroke? So I want to talk a little bit about what the signs and symptoms of a stroke are, and we like the acronym B-FAST. B is for balance. So if you have trouble walking, or if you feel that your balance is off suddenly, this isn't something that happens over a 2-week period. It's if 1 second you can walk fine and the next second you can't. Similarly, if you suddenly lose your vision or suddenly have double vision. F is for face. If your face is drooping, you look in the mirror and your face suddenly looks asymmetric. If you're having weakness in one of your arms, or if one of your arms goes numb, and actually you can test this by simply trying to raise your arms in the air, having your loved one raise their arms in the air. And if one arm falls down quickly or you can't lift the arm at all, then that could be a sign. S is for speech or trouble talking, trouble getting words out, or if your speech is slurred. And the T is for time. You need to get to the hospital immediately and call 911. And we'll talk a little bit later about why that's so important. So what actually is a stroke? There's 2 main types of stroke. One is ischemic and the other is hemorrhagic. The majority of people, around 85% of patients who have strokes, have an ischemic stroke. And the mechanism of an ischemic stroke is exactly the same as what a heart attack is. So if you see here, This is an artery that's going up into your brain, and you see the blood flowing freely through the arteries. This here is a little blockage that someone has developed over time, or a narrowing of the artery, and it looks like a piece of it has broken off and is traveling up the artery and lodges itself. And you can see that the blood flow can't get past this blood clot, and it causes that part of your brain to not get any blood, and that part of the brain will start to die off. Again, exactly the same thing that happens in a heart attack. A blood clot lodges in an artery in your heart, and part of your heart dies as a result. About 15% of people will have a hemorrhagic stroke, and a hemorrhagic stroke is actually kind of the opposite of an ischemic stroke. You can see here that your artery has ruptured, or it starts leaking blood out into your brain, and it causes blood to lie in your brain, and that's what a bleeding or a hemorrhagic stroke is. So if we talk about what an ischemic stroke is, so the blood clot, there's a lot of different causes, and some of these are large medical words, but essentially what it means is around 20% of people will have a blockage in one of their arteries. The most common is carotid artery. You might have a doctor tell you that you have a blockage in your carotid artery and it needs to be fixed. So that causes about 20% of strokes. The other is a blood clot can come from your heart. It's called cardiogenic embolic. A blood clot forms in your heart, and as your heart pumps, it can throw that blood clot up to your brain. The most common cause of this would be AFib, or atrial fibrillation. So some of you might have heard of that, or maybe even have that. Small vessel disease accounts for about 25% of strokes. And if you look at this picture, these are the large artery got blocked. But if you go all the way up here, you have these tiny little arteries which can get narrowed and close off over time. So that's about 25% of stroke cause. It might sound better to have a small artery blockage than a large artery blockage, but actually they both can cause damage, and they both can be serious. About 20% have another cause. So it could be cocaine use. It could be an arterial dissection, which is a tear in your artery. You could have a blood clotting disorder. And then about 20% of strokes, we can't figure out what the cause is. This sounds scary to people, but out of all of these causes, the cause of stroke that's least likely to occur again is if we are the undetermined stroke. So if we can't figure out why they're happening. So who's at risk for a stroke? So I break these into two categories, what the stroke risk factors are. One are modifiable risk factors, and the others on unmodifiable risk factors. So for the unmodifiable ones, are the ones you can't do anything about. You can't help your age, you can't help your sex, your race, ethnicity, or your family history. So you're going to get older, you're born one way or the other, and that's just how it is. But we like to focus on the modifiable risk factors because these are so critical and so important. And the two that are bolded, hypertension, the first one, and tobacco use, are the two biggest, most modifiable risk factors. And the rest of these listed here are important too. But if you're going to change anything, it would be to stop smoking and to control your blood pressure. So this is just a graph that I found that talks about stroke mortality related to your blood pressure and your age. And this first over here is your systolic blood pressure, and the second is diastolic. So your blood pressure comes at 135/90. That first number is the systolic number, and the second number below is the diastolic number, and they're both important. And you can see here the top line, these are age decades, so 80 to 89, 70 to 79. And you can see the blood pressure is on the bottom row, and 120 here, and it's going up. So you can see that your mortality increases in every single age category as your blood pressure goes up. And that's true with both your systolic blood pressure, or your top number, as well as the bottom number. And so blood pressure is really just critical at preventing stroke. And just to talk about a little bit more about how critical this is, people always ask me, well, what blood pressure should I aim for? And the number really is 120/80. And in fact, there have been studies that come out. There was a study out of Cedars-Sinai a few years ago that actually suggested that a lower blood pressure, even of 110/70, is better, particularly in women, at preventing stroke. So if your blood pressure is never in the range of 110 to 120/70 or 80, even if it's always 130/135/85, that's a little too high. You really want to aim for 120 over 80. And this is so important that I'm just going to say this over and over again, 120 over 80. And you want to write that number down and you want to show it to your doctor and say, this is what is going to prevent a stroke and a heart attack. How can I get to this number? So I always tell people, you know, being a stroke doctor is kind of like being a cancer doctor. You might love your cancer doctor, but you kind of wish you'd never met them. Well, the same is true for us. We're happy to help you if you need us, but the best thing you can do is try to prevent a stroke from happening. So how can you do this? How can you control your vascular risk factors? So importantly, you need to see your doctor regularly for a checkup so that he or she can check your blood pressure, your cholesterol, check you for diabetes, make sure that your blood pressure is in that 120 over 80 range. Smoking cessation, I cannot talk about this enough, and everybody knows this, but we also know that smoking is highly addictive. So whatever you can do to stop smoking, talk to your doctor about that. Exercise, always going to be helpful. Diet is helpful. I'm not a nutritionist, but the diet that I prefer for stroke prevention is called the Mediterranean diet. It's really just using good fats and avoiding bad fats. So good fats would be avocados, nuts, olive oil. Bad fats would be red meat, things like that. Limit your alcohol intake. This is controversial. Studies have shown a variety of things, but the general consensus after hundreds of studies is that alcohol in moderation, meaning drinking 1 drink a day, is okay. But an excess of 2, 3, 4 drinks a day increases your stroke risk. So if you have sleep apnea, wear your CPAP. I know they're uncomfortable, but there's many different masks types you can wear now. So try those out because untreated sleep apnea is a risk factor. And finally, if you've had a stroke or a TIA, which is a mini stroke, you want to treat the underlying cause. So if a doctor tells you you had a TIA and your carotid artery is blocked, then there's ways to fix that. Similarly with atrial fibrillation, there's blood thinners that can prevent stroke. Intracranial atherosclerosis, that's a fancy term to mean that those small arteries in your brain are getting plaque in them. So again, it's going to be things like blood pressure control and taking your medications. And this last bullet point, I can't stress enough. I know it's hard to remember to take your medications on a daily basis, but I see so many people who come in with strokes because, oh, I ran out of my Xarelto 2 weeks ago, and I never got it refilled, and then they have a stroke. Or my blood pressure medicine, I stopped taking it because I don't like the way it makes me feel. If you have an issue with your medications, if they're too expensive, if you're not tolerating them, please, please, please talk to your doctor and try and find a different alternative. Okay, so back to Fred here. Fred's tennis partner called 911. And when the ambulance arrived, EMS noted right-sided weakness and aphasia. So aphasia means difficulty getting words out. And so he was transported to our hospital as a code stroke. And we are made aware of code strokes before the patient gets to the hospital. So you'll be, and I'll talk about this in a second, but you'll be met downstairs by a team of doctors and nurses to really help you. So going back to Fred, they found right-sided weakness and aphasia. So going back to this be fast, he already has, so one side of his face is drooping, so that, you know, the F, his arm on the right was weak, and he had speech difficulty or aphasia. So we really met 3 of these letters, and it really looks like now that Fred is having a stroke. So the reason you want to get to the hospital so quickly is because every minute of that blood clot sitting in your artery, your brain loses 1.5 million neurons per minute. So don't worry, your brain has billions of neurons, but this is pretty dramatic. So I have patients who say, oh, I woke up and my right side was weak, but I thought it would go away. So I waited 6, 7, 8 hours. I waited 2 days before coming in. We hear this all the time. And I just want to stress that you are literally losing almost 2 million neurons a minute. Okay, so back to Fred. This is a picture. This is a stage picture in our emergency department. This is a room you will go into if you come in as a code stroke. We have some of our stroke nurses there. We have myself, and then we have one of our stroke nurses acting as a patient. In reality, you're going to be lying in that gurney, and you're going to have 15 people around you, and everyone is doing a different job. You have someone's getting your history, someone's doing an exam, someone's checking your vital signs or drawing labs, and then we send you to get a CAT scan to determine your eligibility for stroke treatment. So when you're in the CAT scanner, this is what we're looking for. So this picture up here, this is your brain of someone having an ischemic stroke, so that blood clot. And actually on CAT scan in the beginning of an ischemic stroke, your brain actually looks pretty normal. So this is a normal CAT scan up here. This one down here is the hemorrhagic or the bleeding stroke. So you can see this looks different than that. You see this big white area here, that's blood. So this is a hemorrhagic stroke. And then we get this really fancy imaging. It's called a CT perfusion scan. And so this on this side is the stroke that's already happened. And you would see pink here in the brain if the part of your brain that's already died. And then this green part here this is the stroke you're going to have if we don't treat you right away. So the blood clot in your brain is blocking off part to this whole part of your brain. This is like Fred, because if you have a stroke here, you're going to have trouble talking and you're going to have right-sided weakness. But Fred got here so quickly that he doesn't have a large core stroke yet. But again, if we don't treat him right away, he's at risk of having quite a large stroke. So how do we treat stroke in the acute setting? So we have more effective treatments at this stage for ischemic stroke or the blood clot than we do for the bleeding strokes. But starting with the bleeding strokes, you come in, you have blood in your brain. What do? We bring your blood pressure down right away. We reverse the effect of any blood thinner you might be on. We talk to our neurosurgery colleagues because there are some neurosurgical procedures that can be done at times when you have blood in your head. And then we monitor you in the ICU and we monitor you very closely and see how you do. So if you have a bleeding stroke, expect these steps to be taken when you go into the emergency department. For an ischemic stroke, we have more effective treatments for those, thankfully, because those are about 85% of our strokes. So we have two different types of therapy. One is called IV thrombolytic therapy. What thrombolytic therapy is, it's literally a clot-busting drug that is injected into your IV. It goes into your vein and that goes into your arteries and all the way up into your brain and literally dissolves the clot. And I'll show you a video of that in a second. And then we have a procedure called a thrombectomy, which Dr. Tarpley is going to talk about next, where you go in through the groin up into the brain and actually mechanically remove that blood clot. So I just want to show you a brief 30-second video on what IV thrombolytic therapy is. And there's two main types. There's TPA or alteplase or TNK and tenecteplase. And they're both very effective. At Providence, we are currently using tenecteplase. We used to use alteplase. Either one is fine. So let's watch this. So this is showing your blood flowing through your arteries in your brain. And over time, you've developed a narrowing here, which people tend to do. And here comes a blood clot and it's lodging in that narrowed space already, and it's preventing any more blood from getting through. So your brain is now dying at a rate of 2 million neurons a minute. So this is the tenecteplase or TPA that's getting entered into your artery, and it comes and it actually literally dissolves the clot on the spot and opens up that artery again. And that really is a way to get blood flowing to your brain again to prevent further death of a part of your brain. Oops. So I love this slide. I think that it's very informative. This is what happens when you get that blood clot drug, the TPA or the tenecteplase. And this visual tool helps us explain to patients what it means, because this medication isn't 100% safe. It is a blood clotting drug. And so the risk is that you could have bleeding events. But if you look at this diagram here, the green, so about a third of the people who get this medication who are having a stroke get better. The bright green people become entirely normal. And then the light green people have improvement after this drug. The people in the middle don't have much of a change getting this drug. But after getting thrombolytic therapy, there's 1 in 100 person that could get severely worse or even die. And then there's 2 people here that could get worse. So it's not 100% safe of a treatment, but really the odds are in your favor that you're either going to get entirely better, mostly better, or you won't have any change. Another way of looking at this, sometimes people respond better to numbers and less well to visual aids, is that after you get a thrombolytic therapy in the emergency department for stroke, the number needed to treat to get one patient back to normal or near normal is 8. So for every 8 patients we treat, one patient is going to become normal or near normal. And for every 3 patients we treat, one is going to become improved. So this is actually extremely effective in terms of treatment for anything. Sometimes you see a number needed to treat as 50 or 75. So for stroke treatment, for any treatment, this is pretty amazing. And what Dr. Tarpley is going to present later, for thrombectomy, the number needed to treat is even better. So for every 100 patients treated with thrombolytic therapy, 32 are benefited and 3 are harmed. Okay, so going back to Fred here. So Fred is having an acute ischemic stroke, and he happens to have one of his large arteries going into his brain is blocked. So he gets the thrombolytic therapy, he gets tenecteplase, and then he gets a mechanical thrombectomy, which is what Dr. Tarpley will talk about. And afterwards, he's admitted to the intensive care unit. So he still has a stroke, and he's after this, but he has a small stroke versus a huge stroke. And he has a little bit of mild right-sided weakness and word finding difficulties, but he's discharged to acute rehab where he spends 2 weeks getting intensive therapy. And within 3 months of his stroke, he's actually returned to his baseline. So without any therapy here, without any tenecteplase or any intervention at all, he was at risk of being severely disabled for the rest of his life. So this is pretty amazing care. So in conclusion, the best way to treat stroke actually is to prevent stroke. And you do that through vascular risk factor modification, such as blood pressure control. You want to stop smoking, you want to regularly see your doctor, and you want to take your meds. If you think you're having a stroke, get to the hospital right away. I can't stress that enough. I always tell patients, if you think you're having a stroke, that's the last thinking I want you to do. I want you to get to the hospital and have us do the rest of the thinking for you. Because just remember the 2 million neurons per minute you're losing. And just remember there are excellent treatments for stroke, but they have to be given immediately. If you come in 24 hours later, your stroke might have already completed. And even if we take out the blood clot, there's no more brain left to save in that area. So I want to thank you for listening to this, and I'm happy to answer any questions at the end because I know we have 2 more speakers who are going to give you a lot of useful information. So thank you.
Thank you, Dr. Arch. That was definitely an informative presentation. What was that blood pressure number again?
120/80, don't forget that.
Thanks. Now it's my pleasure to introduce Dr. Jason Tarpley. Dr. Jason Tarpley is a board-certified neurologist with fellowship training in vascular and interventional neurology. He specializes in the clinical care of patients with neurovascular disorders and has a specific interest in ischemic and hemorrhagic stroke, cerebral aneurysms, and carotid artery stenosis. He is an investigator in many phase 2 and phase 3 clinical studies examining the safety and effectiveness of innovative therapies in stroke patients. He has published many papers and presented his research at domestic and international conferences. Dr. Tarpley serves as a stroke medical director for Pacific Stroke and Neurovascular Center. He is also the clinical lead for Providence's system-wide clinical stroke research. Take it away, Dr. Tarpley.
Thanks, Treasure, and great talk, Allison. Dr. Arch and I work together almost every day, and I think you guys, can think of us as brain plumbers, and it really isn't that complicated, but yeah, very often you can have a clog in your plumbing, and one of the things Dr. Arch talked to you guys about is basically a clot busting medication, which is similar to like Drano. If you have a clog in the drain, you can use Drano. And what I'm going to talk to you about a lot of is what happens when you have a clot that's a little bit too big for the Drano. And that is what's called a large vessel occlusion. And Dr. Arch told you guys about this a little bit, but basically, this is a very, frankly, revolutionary procedure that can be given to people who have a clot. So this person, you're looking at them, this is a big artery in the brain, and Dr. Arch was talking about smaller arteries. This is a big artery in the brain, and so this is a big chunky clot that's stuck in the brain and creating a big problem and lack of blood flow that's causing this patient to lose about 1.9 brain cells a minute. And what we do is we put a catheter in the artery of the leg, believe it or not, which is about the size of an iPhone charging cable. So everyone seems to know how big an iPhone charging cable is, but that's about how big it is. And then we take a catheter through that up into the artery of the neck, another catheter up into the artery of the brain, and basically these telescoping catheters, right? So there's 4 catheters here, which are, skinny catheters that then get navigated all the way up to this blood clot. And then we can pull the clot out, either suck it out or sometimes use a device to grab onto that clot and snare it and pull it out. And this is something that is really one of the most effective therapies in all of medicine. And I want to stress to you guys that it's really only available at comprehensive stroke centers. So you can't get this anywhere, and we're really built for this. This is something that Dr. Arch and I work with every day and evaluate patients, and are really, I think, feel lucky to be able to deliver this very powerful therapy. I'm going to show you guys a quick video of what it kind of looks like here. So this patient, you can imagine, is having a big blood clot that's stuck in the artery right behind his eye here. And there's that blood clot blocking that blood flow, resulting in 2 million neurons dying per minute. And what we can actually do is puncture the groin here and put some devices into the arteries. And the arteries actually serve as byways and highways that will take us, really, we can go anywhere up into the brain. And we'll put the first catheter in here, the second catheter in here. This is actually a wire, and the third catheter is driven over the wire. And then the fourth catheter goes over that. So this is a 4-catheter technique you're looking at here. You pull everything out so that catheter is now unencumbered on the inside, and you can apply automated suction from a fancy pump to this blood clot. Sometimes you can grab the clot and pull it out this way, and sometimes, like what we're seeing here in this video, you can ingest the clot completely, and now you see blood flow restored. So Dr. Arch shows you guys what it looks like when you use a clot busting medication. This is what it looks like when you use a clot retrieval mechanism or treatment. And I want to stress to everybody that these 2 treatments are done in conjunction. Very routinely, we do both of these when patients come in and have their stroke. So this is called endovascular thrombectomy. It's endovascular because we take our catheters and wires and tools inside the arteries. Thrombectomy is removing a clot, and acute ischemic stroke you guys are experts on after Dr. Arch's lecture. So endovascular thrombectomy is a revolution in stroke care, and multiple clinical trials show its dramatic benefit in reducing disability. And it turns out that it's one of the most effective therapies in medicine, with the number needed to treat as low as 2. So it's great that Dr. Arch introduced you to the number needed to treat. But essentially what you can think of this as one of the most effective therapies in all of medicine. So you can imagine how important it is if you're having signs or symptoms of a stroke. The faster we do this therapy, the faster we do thrombolysis, which is what the clot busting medication is, the better you will do. This shows some results from a clinical trial that showed that about slightly over half of the patients who get this thrombectomy procedure will have a positive outcome and be independent at 90 days. And this number is really good because we're talking about with thrombectomy or with large vessel occlusion, we're talking about big clots that block big arteries, and they put at risk a large territory of your brain. So to get 53% of patients to be independent, functionally independent, is amazing, and it's a revolution. And so I think Dr. Arch said it well, that we basically will make big strokes into small strokes, and small strokes are very often recoverable. However, I want to point out to you guys, this is great because without the therapy, almost no one will do well who has a large vessel occlusion. Without the thrombectomy, almost no one will do well. But look at this, we still have 50% of our patients, nearly half anyway, 47% who will end up disabled or dead. And so one of the things that our group here at Providence Little Company of Mary, our clinical group, our neurology group, our neurointerventional group, and also our neurovascular research group is aimed at is how can we benefit? How can we maximize the benefit of endovascular thrombectomy? We're sitting here with this comprehensive stroke center, able to deliver this advanced therapy. And it's amazing, right? Well, I'm going to show you a case of someone who did amazingly, and we see that every day, but we still have room for improvement, and we're doing everything we can. So the way I think of this is that we have multiple ways, multiple angles, it's multiple approaches that we can do to maximize the benefit of thrombectomy. And as you may imagine, one of those ways is what Dr. Arch just talked about, which is giving a thrombolytic therapy, a clot buster. So it turns out that if you get a clot buster, if you're in the window for a clot buster, these two medications work synergistically, and patients tend to do better if they get a clot busting medication. We've actually published a retrospective data analysis on a huge number of patients in the Providence system to show that this is the case. And that's really what our whole research program is geared at, doing both clinical trials and retrospective research from a very large stroke database in the Providence system, where we can actually ask questions of these patients who've had stroke. Stroke is relatively common. Probably most of the people on this Zoom call have known somebody who's had a stroke. So this is a very common disease. What we do is we capture all that data and we look at how patients respond to different therapies, and we can actually see that can actually inform how we treat patients. So that's one of the main things we do as a research organization. That includes techniques. So we have both clinical trials and looking at this retrospective data to look at the best possible technique for reopening the blood vessel. We also have a clinical trial where after someone gets revascularized, after we open up the vessel by pulling out the clot or giving them the clot busting medication, we can actually inject neuronal brain cell stem cells into the area of damage and see if that actually improves patients. We also are using new devices. That includes testing the next generation of catheters like I showed you, or stent retrievers. We also will be doing robotic thrombectomy. I know it sounds like science fiction, but it really is not. We are in a situation we're going to be, Providence Little Company of Mary is going to be procuring a robot where I can actually do sub-millimeter resolution control of catheters and wires by doing robotic neurointervention. So it sounds like science fiction, but we will literally be in a situation where we will be doing robotic delivery of intra-arterial stem cells into the brain. It's really an exciting time to be alive. We're also looking at other ways to maximize the benefit of thrombectomy, including benefiting new populations. So what about patients who, I said that we specialize in making big strokes into small strokes. What if you already have a big stroke? Is it beneficial to reopen the artery and make a massive stroke a large stroke? That's something we're examining with clinical trials. Also, patients who present with a blockage but minimal stroke symptoms, we have a clinical trial to figure out if it's better to intervene on those patients with a thrombectomy or to treat them just with medications. And we're also looking at new targets, so more and more smaller vessels that we can treat. The other thing I wanted to talk about is really what the only thing I have time to really go into in detail, and that is neuroprotection. So there are now significant promising drugs that can actually decrease the rate of death you are experiencing in your brain cells when you're having a stroke. This is super promising, and as a comprehensive stroke center that sees a ton of stroke, we are actually on the forefront, and we're able to bring patients these very promising therapies. So I would love to spend all day talking about all of these wonderful trials and new therapies that we're studying and that we're bringing to patients at Providence Little Company in Marion Torrance and in San Pedro. But the only one I really have time to talk about today is Neurotide. And so I'll get into that now. So Neurotide is a neuroprotectant drug. And I know this slide has a lot of information, but now that you guys have had Dr. Arch's lecture, you're mini stroke experts. So I'm gonna go into this a little bit. Basically, Neurotide, this is a brain cell here, a neuron that is being subject to acute ischemic stroke. So this red lightning bolt symbolizes what happens when that brain cell is lacking blood flow. And actually what happens is this receptor on the surface of the cell called the NMDA receptor gets activated, and it ultimately leads to activation of these intracellular signaling molecules, and it triggers the cell to die. So this cell is sitting there as an innocent bystander, and it realizes that it's sitting there and it suddenly lacks blood flow. It actually gets programmed to die. It doesn't realize that Dr. Arch is standing there ready to give a thrombolytic drug and restore blood flow, or that I'm standing there ready to pull the clot out and restore blood flow. It thinks that its predetermined fate is death. And so then you come along and you restore blood flow, but some of these cells will continue to die because they were programmed to do so. Now, a really close colleague and friend of mine, Mike Timiansky, who's a neurosurgeon, actually a vascular neurosurgeon, really talented basic scientist, has done 20 years of preclinical work to discover and invent a drug called NA1. It used to be called NA1, but now it's called Neurotide. And what Neurotide does is it's kind of like a Trojan horse. It sneaks into the cell, into the brain cell, and it disrupts this interaction of these sort of death molecules and the NMDA receptor. That actually ultimately leads to cell survival rather than that cell dying. So it tells the cell, don't be predetermined to die, and it allows the injury that the brain suffers to be less. And so what's really interesting about this is that it works all over. It works in cultured neurons and rats and mice and everything like that. But the most important thing is that it actually especially works when the ischemia or lack of blood flow to the brain is temporary and followed by reperfusion, which means reopening the artery. So I'll repeat that. That's really important. It especially works when the lack of blood flow to the brain is restored. And in thrombectomy, the procedure I just told you about, we are able to restore blood flow to the brain 90% of the time. Okay, so it's really interesting and promising to target a drug like Neurotide in patients who are getting thrombectomy. And we're very proud to be running this study. I always tell people, if my mother were coming into our hospital with a stroke and needed a thrombectomy, I would enroll her in this clinical trial. And we're proud that at Little Company, this is the only place in Los Angeles that you can have this. All right, so it turns out that this description of what happens with Neurotide is exactly what happens when there's no alteplase. So alteplase and tenecteplase are the two clot busting medications. And it turns out that they actually interact with nerenatide. So in patients who do not get alteplase, nerenatide actually enters the brain cell, blocks cell death, and improves functional outcome. However, with alteplase and tenecteplase, what they do is actually fairly simple. They activate your body's own mechanisms for breaking up blood clots. And they do that through this enzyme called plasmin that's floating around in your blood. And plasmin is floating around in your blood, and it chews up blood clots when you form them in your blood. So if you have a scab, the plasmin will actually chew up that blood clot and clear that up. Alteplase and tenecteplase, the Drano medications, are really acting by using your body's own mechanisms and activating your body's own plasmin. And so that actually is very good at chewing up blood clots and reopening arteries. Unfortunately, it also chews up and inactivates nerenatide. Nerenatide is a peptide. That neuroprotectant drug is a peptide or a protein. And so plasmin actually also chews up and inactivates nerenatide. And you may think, oh, that's a bummer. But on the other hand, I just told you in the beginning that we are looking at multiple ways we can maximize the benefit of thrombectomy. And I said one of those ways is giving thrombolysis. Well, guess what? There's some patients who are not candidates for thrombolysis. So instead of just saying, oh, that's too bad, you can't get TPA, you can't get tenecteplase, here at Providence Little Company, we're able to say, well, we may be able to give these patients nerenatide. And nerenatide turns out to be effective in patients who don't get alteplase and don't get tenecteplase. And so I'm going to show you guys some real data. This is the ESCAPE NA1 trial that we published in the Lancet last year. This shows the primary outcome, which is this is called the modified Rankin scale. And patients who are 0 to 2 on this scale, it means that they're independent, that despite having a very large stroke, they ended up independent. And I told you guys in the beginning that if they get a thrombectomy, 50% of those patients will be independent at 90 days. And that's what we saw with this trial. In the group of patients that did not get alteplase, half of them got placebo and half of them got this neuroprotectant drug, nerenatide. And as expected, the ones in the placebo group, half of them had a good outcome. We opened the vessel and half of them had a good outcome. In the nerenatide group, 59% had a good outcome. So there was a 10% improvement. And that's the way I like to think about our program, is what can we do to edge out and maximize the benefit? Is there something we can do to get you to 60%? Is there something we can do to get you to 70%? It turns out just like I described in that cellular model, there was less death, less patients died in the nerenatide group. So 12% of the patients who got a thrombectomy died if they were given nerenatide, while 20% died if they were given placebo. And actually, as we said, that I basically specialize in making big strokes into small strokes. Small strokes are more recoverable, as you'll learn from Julie. In patients who got nerenatide, the actual size of the stroke that they ended up with was 26.7 milliliters compared with 39.2 milliliters in the group that did not get nerenatide. So this is super promising. This is like the next wave of what's going to happen in neuroscience and stroke. And I cannot be happier to be able to be delivering this therapy at Providence Little Company of Mary. I'm going to give you guys a case presentation. This is a real patient who presented to us just about a month ago. She had a young woman, 43 years old. She presented to the ER. She was normal the night before. Okay. And she had a history of cancer, but she was in remission. And she had a history of a blood clot in her leg, which turns out to be a clue. And she was normal the night before at 2300, 11 p.m. the night before. That's her last known well time. That's when she was at her normal baseline. She went to bed. And then when she woke up in the morning, she was completely paralyzed on the left, in the left face, in the left arm. She had her gaze, her eyes were looking over to the right and they could not go over to the left. And she couldn't see at all. She was completely blind in the left side of the world. This is something we encounter all the time. This is what we would call her NIH stroke scale is 16. So this is a very high stroke scale. This is not a small vessel stroke. This is a large stroke causing significant at-risk territory. This shows eventually the patient was taken emergently to the cath lab, but before she went there, she had this fancy perfusion scan that you guys are already were already introduced to. On the right side here, it shows the amount of territory that this patient is predicted to have dead already, and that's 89. So that's actually pretty large amount of brain that is already seeming to be dead. However, this is what's going to die if you do not open the vessel. So if you don't open the vessel, this is going to be the stroke that this patient gets. It's very big, much bigger than this small stroke that the patient's going to have if you open the vessel. This patient is a little bit complicated because it turns out that this overestimated her core infarct, but that's not important for the purposes here. For the purposes here, I want you guys to recognize that we have this patient here who we have the ability to turn this stroke into this stroke, to turn this massive stroke into a small to medium-sized stroke. And so this is what it looks like. I told you guys that we navigate a catheter up into the artery of the neck and we do our procedure, and I showed you these cool pictures that are all colorful and with very calming music playing in the background. This is what it actually looks like. I have my catheter here in the artery. This is at the base of the brain, and I shoot this contrast dye into the arteries of the brain. And you see that this big artery just stops, right? We're not actually seeing the clot. We just see that that artery stops. What's really interesting is that this is an alternative artery. It's almost like the 405 is blocked and Sepulveda is open, and it's trying to get blood flow into this territory. And it's giving us a little bit of time, but ultimately this large territory, as you saw in the previous slide, is going to die if we don't get this vessel open. And very quickly, we navigate that 4-catheter technique, a catheter within a catheter within a catheter within a catheter. We pull out the middle one, and we actually suck out this blood clot, completely restoring blood flow in this entire vascular tree. This patient received this thrombectomy for this is the right internal carotid artery, what I just showed you. And what she had was a door to device of 55 minutes. What this means is between the time that she hit the door and Dr. Arch saw this patient in the hospital, and when she was transferred to me and to our team to go up and pull the blood clot out, it took us only 55 minutes from the time she hit the door to pull that blood clot out. And that's actually lightning fast. The goal is to have 50% of your patients be under 90 minutes. So hitting a 55-minute is just really sets this patient up for her best possible outcome. And actually her medical contact to the time that we pulled the clot out was 83 minutes. So, this is pretty remarkable. This is pretty remarkable collaboration with our EMS colleagues that, when the goal is across LA is to get a door to device, meaning they hit our ER to getting the clot out in 90 minutes. And we got that, under 90 minutes between when the ambulance picked them up and we got the clot out. That's really dramatic. And that's when it's very unsurprising that the patient ended up having a very small stroke and was discharged to home at her baseline. So this was a dramatic win. This patient didn't even have to go to rehab. She didn't, she went straight home. She's at her normal baseline. I see her in clinic. She's active. It turns out she had a patent foramen ovale, which is the cause of her stroke, which is a connection between the right and left sides of her heart. And in fact, she's just underwent closure of that at our hospital today with actually Dr. Kaushal. I like to think about this case as like the home run case that about 50% of our patients will have. But I also want to kind of come back and remind you guys that, again, it's only 50% of our patients that will have this. So our group, what we're really interested in is figuring out any possible way we can help those other 50% achieve the same outcome. And just to give you the last slide here is, I think it's all about taking a multi-pronged approach to maximizing the benefit of this powerful therapy. And it's a good segue to talk about rehab now, because in many of our patients, it's not a home run. What I just described to you was a home run. In many of our patients, we turn a massive stroke into a small stroke, and that small stroke they still have to recover from. And the way I think of it is, in those patients, you hit a double. And Julie Wang, our rehab liaison, will talk to you about the program at San Pedro and at Little Company of Mary, where we basically get the RBI, speech and language pathology, physical therapy, occupational therapy, can retrain somebody, retrain the areas of undamaged brain to pick up the job of the damaged brain, the injured brain, and can significantly benefit patients. And that really deserves its own arrow here. And with that, I'll turn it back over to you, Treasure. And guys, I don't know if I'm going to try to stick around for questions, but I have a possible ruptured aneurysm in the ER. So when they're ready for me, I'm going to have to go. And Treasure, I'll let you introduce Julie. Thanks everybody for your attention.
Awesome. Thank you, Dr. Tarpley, for that interesting presentation. I want to share with you all that Dr. Tarpley spends an extensive amount of time doing outreach to our EMS providers in our local paramedic and fire stations, so that they can actually recognize what a big stroke is, know how important it is to get in, and they're able to guide you and get you to the hospital that can appropriately care for you. So thank you, Dr. Tarpley, for that and all that you do. Before I introduce our next presenter this evening, we will be sharing a short video showing our comprehensive rehabilitation services offered at Providence Little Company of Mary Medical Centers, or Medical Center San Pedro's Rehab Center. Now, to talk a little bit more about what you just saw. Oh, go ahead, the video.
Selecting a rehabilitation care provider is the first step in regaining independence. It is the place where patients work to regain mobility, learn to remaster everyday activities, and strive to return home. The Acute Rehabilitation Program at Providence Little Company of Mary Medical Center, San Pedro, has been rated nationally for successful patient outcomes and is accredited for adult medical rehabilitation and stroke specialty. Under the direction of Dr. Ann Long, the interdisciplinary team develops a personalized treatment program utilizing the latest therapeutic techniques and state-of-the-art equipment funded by generous donations from former patients.
Rehabilitation is almost like a school that we take our patients as a whole, and they usually have some kind of condition that impair their functional mobility and activity of daily living. Our goal is to maximize their functional potentials, train their families so that they can go home and go back to their community. Most of our patients have some kind of neurological conditions. We have spinal cord injury, traumatic brain injury, multiple trauma patients. We have been getting quite many liver, heart, and lung transplant patients from UCLA.
The patient's journey often begins with a community liaison.
When I first make contact with a patient who's referred to the Acute Rehab Center, they generally want to know what this is all about. So I usually tell them that we are a hospital. They will be medically monitored and taken care of 24/7. But instead of being in their hospital bed for the majority of the day, they will be participating in 3 to 5 hours of therapy.
So working here is not like a regular floor. It's still a regular floor in the sense of medications, treatment. We take care of all of that. But it's here we work on all aspects. Their mental, emotional, spiritual, all aspects are important for wholeness.
Physical therapists create a treatment plan aimed at increasing mobility and endurance.
When we evaluate the patient, even though we have this diagnosis 10 times a week, it's going to be very different for that patient. Each discipline is exacting in their approach of what specifically that patient will need.
Physical therapy really emphasized learning how to walk again. I was in the exoskeleton for a few times to learn how to move my leg. It's a controlled movement.
When I had the accident, the diagnosis was that I would end up being a quadriplegic. When I got to the Acute Rehab Center, therapy techs here were very serious about what it is that they do. Came up with a work plan that would get me to where it was that I said that I wanted to be.
Occupational therapists help patients remaster everyday activities.
Occupational therapy, we are here to help you resume your independence and your daily life skills. We want to help people resume participation in their daily life activities.
Initially, I could do most nothing myself. I had to learn how to put on my socks. I had to learn how to put on clothes. I had to learn how to pick up things.
Our hope for a patient leaving acute rehabilitation would be to resume some small forms of independence. We don't expect total independence by the time they leave us, but ideally we'd love for them to be able to feed themselves, or at least get out of bed by themselves.
Speech-language pathologists help patients with speech and communication, but that's just one aspect.
We also work with cognition, such as memory, attention, problem solving, and we work with swallowing, so making sure that swallowing is safe after a stroke.
He wasn't speaking, he wasn't eating without being fed. And after he came here, they started working in therapy right away, and he began showing progress. I loved how they worked with him.
Each patient's therapeutic team meets frequently to discuss progress and to adjust the rehabilitation plan. In addition to individualized daily therapy, patients also take part in recreational therapy.
This is an extremely beneficial therapeutic practice. It allows the patient to get their mind off of the life stressors that they've been encountering and just take a break for a moment.
The Rehab Center offers educational support groups and a dedicated psychologist for patients and families, ensuring the patient's safe re-entry into the community as the final goal. The Rehab Center is located within a hospital, providing access to 24-hour medical services, as well as many other specialty programs. As part of discharge planning, the rehabilitation team may visit the home environment and make recommendations on equipment, furniture layout, and accessibility issues. Located in San Pedro, the Rehab Center at Little Company of Mary Medical Center has helped thousands of patients on their journey back towards independence for almost 4 decades.
In the midst of my accident, I have talked to a ton of people who have gone through similar injuries that are nowhere near as well off as I am right now. And I'm certain it has to do with that team.
This is not something I could do myself. A lot of people helped, a lot of staff.
I am so grateful.
The Acute Rehab Center means the world to me because they have given me my world back. This is absolutely the most special place for rehab.
Now to talk a little bit about what you just saw, it is my pleasure to introduce Julie Wong. Julie Wong is a licensed physical therapist who has been working at Providence Little Company of Mary Medical Center, San Pedro for 19 years as the clinical liaison for acute rehabilitation. She evaluates patients who need acute rehabilitation and coordinates with patient, family, insurance, medical team for a smooth transition to the acute rehab. Julie has been a physical therapist for 31 years, specializing in rehabilitation of neurological patients. Her expertise is in the areas of stroke, spinal cord injury, gait analysis, and wheelchair and seating evaluation. Julie has been an active member of the California Physical Therapy Association with previous service as the secretary and district representative. She is presented at conference on aquatic therapy for neurological patients and at physical therapy schools for wheelchair and seating evaluation and gait analysis. Julie enjoys sharing her passion for rehab and swimming, and you may find her swimming in the ocean during the summer. Take it away, Julie.
Thank you, Treasure. Okay, let me share this screen with you. Okay, so I'm here tonight to talk to you about the rehabilitation. And a lot of people may ask themselves, what is so special about acute rehab? So I'm here to tell you about that tonight. Oops, there we go. So the rehabilitation consists of a team, and our job is to work together to maximize functional recovery. And tonight we're going to talk about functional recovery from a stroke. We are actually CARF certified, which is an acute rehabilitation certification group that has specialized our acute rehabilitation as a stroke specialty rehabilitation. We're also UDS rated in the top 1% of the nation. And basically what they look at is the outcomes of how patients do in the rehabilitation by looking at how many, what percentage of people go home, what type of improvements people made in the rehab, and then they collaborate all that data based on rehabilitations across the entire nation, and then they rank rehabilitation. So, so we're rated in the top 1%. Our team consists of a rehabilitation doctor, neuropsychologist, rehabilitation nurse, physical therapist, occupational therapist, speech therapist, recreational therapist, and case manager. And then I'm going to go into a little bit more about what each person does as we go through this quick slideshow here. So the rehabilitation doctors, we have Dr. Long, who's our medical director, and then Dr. Sheedy, who's our other rehabilitation physician. And they basically, each of them sees about half of the team that we have on our rehabilitation. They specialize, they're medical doctors, and they specialize in rehabilitation, pain management, certain neurologic issues that you can see when you have had a stroke, and then coordinating future rehabilitation, which might look like outpatient or home health therapy, or some sort of like a comprehensive day program type rehabilitation. We also have our neuropsychologist, Dr. Sherman, and he focuses on 2 areas, or actually 3 areas. He focuses on cognition. So if there's been any changes in a patient's thinking or memory or ability to be able to divide their attention between 2 different tasks, which we might look at as like multitasking, then he will address these issues. Also, if people have had a stroke and it significantly changed their function, their lifestyle, just, you know, how things were before, then that can also be stressful to people. People can be frustrated or maybe even a little depressed about that. So Dr. Sherman will help with that as well. Dr. Sherman can also help kind of determine if after having had a stroke, if people are competent to be making big decisions, or if maybe a family member should step in and be helpful with making some big decisions. We have the rehabilitation nurses, and they are do things that regular nurses do, but they also specialize in helping patients with their transfers the way a therapist might do that. So the idea is to get out of bed and not stay in bed like you are in the hospital, but to be out of bed like you are at home. And then they specialize in the bowel and bladder program to make sure that people are comfortable getting themselves to and from the restroom. And on the rehab, we definitely hear that this is a top priority for most people to be completely independent in this area. In the video, you were able to see some examples of our robotic exoskeleton, and this is our newest piece of equipment that we've had for, I want to say, about 4 years or so. This is a revolutionary piece of equipment that we have on our acute rehab, and there's actually not a lot of rehabilitations that have this. And it utilizes some of the things that we knew as physical therapists many years ago, but now they're just starting to be able to prove with focal MRIs, showing brain recovery after doing very intensive therapy to help you with your functional recovery, especially when we focus on some of the areas of weakness after having had a stroke. So with this robotic exoskeleton, you can walk in like complete robotic mode where the exoskeleton actually walks for you. And we usually start people out here because we find this is very important to get the proper sensation of what natural walking should feel like. And then we can go into assisted mode, which is where you do as much as you possibly can, and then the robot picks up and does what you're not doing. And obviously the ideal situation is that you're doing more and more and the robot's doing less and less. And we also have our body weight supported walking system as well. And you can see this, you can use it just on the ground or on the treadmill. Basically you could start coming back to walking at, let's say, 50% of your body weight, where you're just walking with that amount. And then we slowly start adding more and more of your body weight into your walking until you feel more comfortable with your walking. We have physical therapists that specialize in Pilates, and we all know that the trunk is super important for movement, because if your trunk is not stable, it's hard to move anything else. We have electrical stimulation that we utilize on the leg ankle area. And what this helps people do is activate the proper muscles that are needed during walking. So for instance, if you need to bend your foot up when you're taking a step so it doesn't drag on the ground, then this will help with whatever you're not able to do. So this is actually a patient of ours who had a stroke, came to acute rehab, wasn't able to walk, and his goal was to walk his daughter down the aisle when she got married, which was a few months after acute rehab. So I'm happy to say he attained his goal of being able to walk down the aisle. We focus in lymphedema. So if people have some swelling, maybe due to lack of movement that causes their lymph system to not be able to clear the swelling as much as possible, we have specialists in that. We also focus on what we call constraint force use. But basically, this is just a fancy way of saying that we are really trying to get people to use their weak side so that they can maximize the mind-body connection between their brain, which is going to be like a little bit of a new area of their brain that they're using that's just adjacent to where they had the stroke, to regain some of their function. Because basically, as we all know, the more and more you practice, the better and better it gets. It's like learning a new dance or a new sport. We have certified yoga instructors. We also focus in vision therapy. A lot of times, if you have a stroke, there's certain areas in your brain that can affect your vision. So we do have occupational therapists that specialize in vision, and then they also work together with neuro-optometrists. And then usually after the rehabilitation, we'll have our patients follow up with a neuro-optometrist as well. One thing that we all know about in California is that we all like to drive and oftentimes need our cars to get around. So a big goal of a lot of our patients is to be able to return back to driving. So we have Purnima, who is an occupational therapist, but also our driving specialist, who will work hand in hand with the patients and then the DMV, and then if necessary, a driving instructor to help people get back to driving. We have some specialty electronic devices for the arm, the robotic myo arm, and we also have the BioNest, and this helps with grasp and release. And then additionally, we have the hand specialist that specializes in people who need specific fine motor hand therapies. Speech therapy does cognitive therapy to help people with thinking, concentration, memory, reading comprehension. And they also work on swallow therapy. So what we'll do is we'll take people to our video swallow lab, and we'll have them swallow different textures that have a little bit of barium in it, and then we can see the food or the liquid or what have you in their pharyngeal area, and then we can tell if they're swallowing properly and it's going down to their stomach, or if they're having trouble and it's going into their lungs. We really want people to return back to whatever it is that they want to be able to do and what they were doing before. That could look like golf. That could look like cooking. That could look like just taking care of general home tasks. We have therapists that can help with any type of equipment needs that could look like wheelchair or seating needs, or even environmental control needs. We can be helpful with that as well. I know Dr. Arch mentioned earlier in her talk about modifiable risk factors. And so we are doing stroke education to go over what those risk factors are and how to stay on top of the risk factors so that you can prevent future strokes and not need to come back to the hospital and see all of us. This is just a quick picture of our staff. So I wanted to thank you for your time in letting me share our rehabilitation with you. And if there's any questions, I can be reached by cell phone or email, or obviously in this talk here tonight as well. Thank you.
Thank you, Julie, for that informative presentation. And before we begin our Q&A, we have a few questions for you. If you could please answer the poll that you see appear on the screen and give us your honest feedback, we would greatly appreciate it. Now we'll go ahead and get to those questions. And as we answer these questions, feel free if any other questions pop up to type them in, and we'll do our best to get them. Okay, so the first question we have here is from Kazi Pastrick. And there's a little bit of information in here, but basically it comes down to having some sensation in the left leg that is painful and it feels like it's on fire. Dr. Arch or Dr. Tarpley, can you answer that for me?
Yeah, I read the question, and thank you for giving the question. It sounds like I forget, it was your dad or loved one had had a stroke, and now they're having burning pain in their leg afterwards. So it may or may not be the result of the stroke. Sometimes if the stroke affects part of your brain that controls sensation in your body, as that part of the brain heals, it can heal a little bit incorrectly, and it can lead to painful sensations. People often describe it as it feels like it's on fire, or electric currents, or pins and needles. So whoever this happened to should be evaluated by a primary care doctor and a neurologist to see if that's the cause of a stroke or what the other possible cause of the burning pain could be.
Great, thank you. And the next question is from Karen Dunbar. Is there a time limit from the initial onset to being able to receive TPA? Dr. Tarpley?
Well, yeah, or Dr. Arch can answer it. There is a conventional time window for TPA, which is 4.5 hours. However, with both the clot busting medication and the thrombectomy procedure, we are moving towards a new world where we don't limit the therapy to clock time. We actually use brain time. And that's what that fancy perfusion scan was that both Dr. Arch and I love to look at. Even when we're not on call, we can't stay away, because that tells you what is salvageable. And it basically tells you how fast that person is progressing with their stroke. So we mentioned that in general, you're losing about 2 million brain cells a minute. Well, the truth is that not everyone's losing it at the same rate. Some people lose 100, some people lose 1 million a minute, some people lose 3 million. And on average, we're all when you're having a stroke, you're losing about 2 million. And so that brain scan that looks at our brain time can actually be something that's probably more useful than your clock time at determining whether you're a candidate for either the clot busting medication or thrombectomy.
Thanks, Dr. Tarpley. The next question we have is, can a fall where one hits their head on a hard surface cause a stroke?
So it can cause bleeding in the brain. If you hit your head on a hard surface, and you're experiencing symptoms of severe headaches or nausea, vomiting, or confusion, or anything else like that, you need to get it checked out. So it can cause bleeding in the brain, and you can think of it similarly to the hemorrhagic or bleeding kind of stroke, except this time it's caused from trauma instead of from a different cause.
Thanks, Dr. Arch. The next question we have is from Peggy Costello. Is a Watchman better than Eliquis?
Yeah, so I read that your question, and that you'd had a GI bleed and required transfusion. So now your doctor is recommending a Watchman device. So people take blood thinners for atrial fibrillation to prevent blood clots from forming. They are very effective. And the newer ones, Eliquis, Xarelto, Pradaxa, have much, much lower bleeding risks than the previous one, which was Coumadin. However, there is a small subset of people who cannot tolerate blood thinners for a variety of reasons, one of which is if they have really bad bleeding requiring transfusions. So in those patients, you can get evaluated for a device called a Watchman device. There have not really been any good trials, large clinical trials comparing Eliquis to a Watchman device. So the thought is at this time, you should really be taking a blood thinner unless you cannot tolerate it. And in your case, if you can't tolerate it, I think a Watchman is a good second choice, but it's not per se better than Eliquis. It's just a different way to prevent stroke.
Next question is, what happens next when a paramedic decides a person is having a stroke before they arrive to the ED?
Sure, I can take it if you like. But so we instituted a really effective routing policy in Los Angeles County in collaboration with the LA County EMS providers in January of 2018. So since actually January 5th, 2018, EMS providers will do a quick scale on you, and they will try to assess in the pre-hospital setting with no imaging, no CT scans. They'll try to assess whether your stroke is severe or not severe. And if it's severe, they will bring you to a comprehensive stroke center, which there are much fewer than a primary stroke center. And so that's actually a really important question, because the advanced therapies that we're talking about are really only available at us comprehensive stroke centers. And so, the pre-hospital scale performed by the paramedics is of utmost importance, actually.
Thanks, Dr. Tarpley. The next question we have is related to a father who's had challenges in maintaining his blood pressure. And so the question is, how can we help him have a level blood pressure without the constant dizziness?
Yeah, so blood pressure is really challenging. Some people just need a low dose of one medication and their blood pressure is perfect. And other people, like your dad, have what's called brittle blood pressure, difficult to control blood pressure, where it just bounces up and down. So what I recommend for these people, and there should be a right combination for him out there to keep his blood pressure at a steady level state, but he just might not have found it yet. So I recommend frequent visits to your primary care doctor, literally every 2 weeks, every 2 to 4 weeks, trying to make medication adjustments and checking on blood pressure until the right medication combination has been found. But this can be a problem with a lot of people, so he's not alone there. And in terms of the dizziness, that could also be a variety of things. One of his medications might be making him feel dizzy. If his blood pressure drops too low, it might be making him feel dizzy. So I would really recommend frequent, regular visits, primary care every 2 to 4 weeks until he's starting to feel better with a more stable blood pressure.
Dr. Arch, do you think maybe it would, do you find it be helpful for patients to keep a log of when they take their blood pressure? And what times is helpful for them to take their blood pressure so that they can bring that information back to the doctor?
So that's a really good question. Thank you for asking it. I love it when patients give me a piece of paper with blood pressure logs. It is so helpful for any physician to look at. I recommend patients not go crazy with it. Take it once a day, take it 3 times a week. But I have some people recording like 5 times a day. I don't want it to run your life. In terms of what time a day, I actually recommend recording the time and taking it at a different time every day. So morning one day, 2 days later, take it in the afternoon, 2 days later, take it in the evening, because people's blood pressure does fluctuate morning to night. And it helps the physician know, okay, I see your morning levels have been okay, but your nighttime levels are high. And then your primary care physician, he or she can do a medication adjustment that fits that. So try taking it at different times, certainly.
And I would second that, guys. The person who asked that question, they said that their father, I think, had a stent placed in the artery of the brain. And so I don't know if it was I who placed it, but I can tell you that when that is the reason he had narrowing in the artery in his brain to begin with is from the blood pressure. And so I think it's really easy to get frustrated and for people to go to their PCP and be like, well, he tried this and it didn't work. But that's actually the normal course. It's a matter of tinkering. And so it's really about determination and like keep going back, like Dr. Arch said, every 2 weeks. And you say, yeah, that didn't work. Let's try something else. And if you're determined, you can get there.
Thanks, Dr. Tarpley. I have another question here. How long does it take for peripheral vision loss to come back after a TIA?
So vision loss after a stroke is hard. You should not have permanent vision loss after a TIA. So if that's the diagnosis that they gave you, that's incorrect. But you can have permanent vision loss from a stroke. And vision loss, in my experience, is one of the hardest things to get back after a stroke. You can have a small stroke in your vision center and have permanent vision loss versus a huge stroke in your motor center, and your strength can recover fully. I'm not quite sure why that is. It's just a harder part of the brain to recover. It's not that it can't recover, but it's just slower and might not be as complete as other parts of the brain. In terms of stroke recovery in general tends to be slow. The majority of it happens within the first 6 months after a stroke. After the 6-month mark, you can still recover, but the timeline slows down a little bit. So yeah, vision loss is tough, and it's one of those things that is harder to recover than other deficits.
The next question is, do you recommend to take aspirin when you suspect stroke after calling 911?
No.
Yeah, no.
The reason is that, Doctor, I'll just go back and forth with you, Allison, so you don't get hoarse. But you don't know what kind of stroke it is, and it could be a burst pipe or it could be a clogged pipe. And if it's a burst pipe, bleeding in the brain, aspirin is one of the worst things you can do. So what we recommend you do is call 911, get to us right away, and we will figure it out very fast. So yeah, we don't recommend taking aspirin. It's a good question. And actually we see it all the time, right? We see patients who say, well, I lost my vision, so I took an aspirin, and when they come in, they actually have a hemorrhagic stroke rather than an ischemic one. So they did something that actually endangered themselves.
All right, thank you for that. The next question is from David, and he says, so the paramedics may take a patient to the hospital that is further away, even if it means taking longer to begin treatment?
I mean, if it's okay, I will say yes, but comprehensive stroke centers not only have really advanced therapies like the thrombectomy we talked about, or aneurysm treatments, et cetera, but they also are very tuned for delivering thrombolytic drugs. And so we actually published this after the routing rules in Los Angeles. We looked at before the routing rules and after the routing rules, and we saw that by taking patients directly to comprehensive stroke centers, you might think that it took longer to deliver clot busting medication like TPA and tenecteplase, but actually what we saw in that data is that even though they drove slightly farther, they got the medications faster. And so it's a really good question, because they're not going to pick you up and drive 3 hours to a comprehensive stroke center. We have enough in Los Angeles that you will never have to go more than 15 or 20 minutes out of your way to get to the best center if you're having a severe stroke.
And if you think about it, if you're having a large vessel occlusion and you're driven to a hospital that's not a comprehensive stroke center, they're going to have to then transport you to a comprehensive stroke center to get care. So that's making 2 stops instead of 1. And so you would actually get faster care if you went directly to the comprehensive stroke center. It's actually similar if you got into a really bad car accident, they're going to transport you to a trauma center. They're not going to transport you to a hospital that's not considered a trauma center, even if that hospital might be closer.
Yeah, and keeping with that, we looked at this in the Providence Center, and for me, it's easy to open the artery whether you come in via the ambulance or whether another hospital transfers you to us. But we looked at it, and because it requires so much time to be delivered to a non-comprehensive and be transferred, we actually saw that patients were 5 times more likely to end up disabled or dead if they had to be transferred to receive their thrombectomy. And that data was one of the things that really drove the LA County to make really a very wise and advanced decision to route people directly to comprehensive centers.
We're going to leave it at that since it's 7 o'clock. I just want to thank you all for taking the time to listen and ask questions. And a big thanks to Dr. Arch, Dr. Tarpley, and Julie for taking the time to provide us with this valuable information. We will be sending a recording of the presentation to all attendees for you to have. And we will be posting this on our Facebook page for everyone to be able to view and share. You can find us at Little Company of Mary South Bay on Facebook, all one word. And for any additional information or to schedule a physician appointment, please call our Patient Engagement Center at 1-888-HEALING. Thank you again, and have a great rest of your evening.
Thank you, everyone.
Thanks, everybody.